All right, welcome everyone to another virtual shadowing session, actually our last of the spring 2022 semester. This is a great one we're going to be ending off on. Today we're going to be joined by Dr. Carrie Dutton, who's a practicing pediatrician in the Dallas-Fort Worth area with around 25 years of experience. She has seen many challenges and changes in the lives of families, teenagers, and young adults. She'll be bringing her expertise today to talk all about pediatrics and medicine at large to really help us as pre-health students know where we can navigate in the future. This is definitely going to be a great session. I'm very excited for it. Glad we could get it together. And a few reminders for people who are new to virtual shadowing and just listening in. We will have these sessions with different specialties and different speakers. There will be a quiz at the very end, 10 questions, and you need to pass with at least 60% or more on your first attempt. You'll be receiving a certificate with the email that you provided in your quiz. And that's just the process of how our shadowing program works. We'll have 2 Q&A sessions today, since this is going to be a 2-hour session going from 7 to 9 Central. And during those Q&As, we'll be going through the questions that you put in the chat. So for any questions you have, type them in the chat and we'll be getting to them soon. For those who'd like to stay updated with future shadowing sessions, you can do that through 2 ways. Either follow us on Instagram, where we post designs, graphic designs for upcoming sessions to let you know that it's going to be that upcoming week. Or you can join us over our listserv, where we send out email announcements for not only our shadowing program, but also a few other things that are gathering along, more programs that we're releasing, especially this summer. So definitely stay tuned to that. We're really using both of them for letting you know about these updates and announcements, but you're free to join in on both. If you'd like to join in through our listserv, just email us at shadowing.h4h@gmail.com, and you can just ask to join our listserv with your name and email. We'll join you in. So it's going to be no problem that way. But with all those reminders covered and with that quick introduction, I don't want to take up more time. Dr. Dutton, feel free to take it away.
All right. It's such a joy to be with you tonight. And it's one of those things that it's one of those few things that I have looked forward to doing, and at the same time hope that it becomes obsolete soon. And what I mean by that is I really hope you all get back into offices. And I really hope that you get back into hospitals and into emergency rooms. You need to get within a few feet and get your hands on some patients. And I think that's such an important part of medicine. So I graduated from residency in 1993. So that means next year is my 30th year in practice, which is crazy. But I want you to know that even 30 years into practice, the words on this slide still are what I feel about medicine, about practicing in the healthcare field. I want you to know it is fascinating, thought-provoking, fulfilling, intriguing, challenging many times, always engaging with the patients. And I just wanted to say that I still am surprised. I still see diagnosis I haven't seen, not very often at 30 years out, but I still am surprised every once in a while. I'm still having to get online and look up new information on what are the tests to run on this. And so I encourage you to go into your pre-med training and go into your thoughts of medical school, just knowing that what you're going into is an amazing, fascinating, honorable field. Next slide. Real quick, I just wanted to let you know I did my undergraduate at Baylor University in Waco, Texas. So I was there 1982 to 1986. Next slide. Did my medical school was at UT Houston Medical School, was there 86 through 90. And then I had the privilege of doing my pediatric residency at Vanderbilt Children's Hospital. I thoroughly enjoyed all 3 of those locations. Just exciting research going on. And at Vanderbilt, you know, Tennessee has, I think, 6 or 7 states that surround it. Georgia and just, I mean, we had kids, the sickest of kids sent from all around. And so I got to see a lot of different things. And I really appreciated the training that I got at all 3, both in college, medical school, and residency. Next slide. So in general, I was asked to talk about life in pediatrics. But I also have thoughts on primary care in general, whether that's family medicine, internal medicine. We've got the slide up here. If you want to contact me at some point after the time that we've spent, the email you can contact me at is speaklifeng@gmail.com. I also have a website specifically to encourage the heart of those that are 15 to 25 years old. And that is speaklifeng.net. So that is a site that you can go to. And I also have been pulling over the virtual shadowing things into a section on that. That's next generation healthcare providers. All right, next slide. So medical training. Oh my goodness, the slide's a little bit off, but that's okay. Number one, stay fascinated and intrigued. I cannot even tell you how much of a difference that can make in getting through all that medicine requires of you. If you, as you are studying the kidneys, studying the liver, studying the heart, if you can just stay at a place of going, this is amazing. This is absolutely amazing, because as far as I'm concerned, the body, the physical body is the most fascinating, the most complex and integrated computer system that's ever been created. That's how I think about the human body. The most complex and integrated computer system that's ever been created. All the systems that interact with each other, the hormones that go from your thyroid to your cells, and the growth hormone that interacts with your thyroid and your cortisol. And it's just an amazing thing. And I do just encourage you to try to stay fascinated and intrigued as you're listening to the different lectures and the labs that you're in. The second point I want to say to all of you is there are many, many times that you're going to feel overwhelmed in medical training when you're learning about organ systems or pathology. And I just want to say, start practicing the sentence, overwhelmed does not mean inadequate. Overwhelmed does not mean inadequate. Feeling overwhelmed does not mean I'm inadequate. For some of you that even felt stressed most of college, you've really got to get that in place before you're heading towards medical school, to realize that being overwhelmed is not the same as feeling inadequate. I also want to say that medical training, pre-health training, whatever that is, whether that's becoming an RN, a nurse practitioner, PT, OT, speech, as well as a medical physician, your years of medical training are your time to demand to understand. So there's no silly questions. I had a reputation in medical school and residency of being the one that would raise my hand in the conference center of 200 students and would just say to the professor, could you stop? Could you explain that a different way? I'm not really following what you're saying. I didn't get that. Could you say it a different way? And after class, I would have 10 or 15 different people every time that would stop me and say, thank you for stopping. Thank you for asking them to explain it differently, because I was totally lost. And so I want to encourage you, remember, their job is to be teaching you. Their job is to be training you. So it's okay to ask for an additional explanation. It's okay to admit this isn't clicking in my brain. Could it be understood a different way? And complexity, understanding the complexity of the human body really does require perseverance. So you're going to have to string a lot of information in a row to sometimes understand disease processes and what labs should be ordered, what different studies needed to be looked at, what illnesses present in the same way, but they're a different illness. So there's just all kinds of levels of complexity that will require perseverance going into it. I think you should head into pre-health training expecting to work harder than you've ever worked for anything in your life. Just go into it with that thought process. I'm going to have to work harder than anything I've worked for before. And that's okay. It's okay for medicine to demand that of you, is what I want to just to remind you. It's just really okay for medicine to demand that this is the hardest you've ever worked for something. But again, if you can stay within the understanding, it's the hardest you've worked for something because the human body is so wonderfully complex and so fascinatingly integrated that it takes that. The next point on just medical training in general, I call specialty pearls. And that is, I don't know how different residencies do it, but in our residency on Fridays at lunch, the different specialists like pediatric neurologists, pediatric oncologists, pediatric rheumatologists would come for Friday lunches, and they would talk about their specialty for an hour. In my practice, those short, brief talks have been vital, have been absolutely vital. And I'm going to share right now a few stories with you talking about how those specialty talks actually prepared me for things I saw in private practice, because it really did matter. My very first year out in practice, I was seeing a 3-year-old for leg pain. And the parents saw a family medicine doctor in town, and they had always taken their child to the family doctor for the first 3 years of his life. So they had gone to their family doctor maybe 4 weeks before, and he had said, you know what, he's a growing boy. He's probably just had a height spurt. It's probably just growing pains. Nothing to worry about. Sometimes our legs are sore for a couple of weeks and then it gets better. And that's probably exactly what I would have done the first time I saw him. If I had examined his legs and didn't find anything particularly worrisome, I probably would have said the same thing. Then I think it was 2 weeks later, they take him back to their family doctor, and they're saying, now it's like he's limping sometimes, or he's not playing as long as he used to. He'll stop. He'll come inside because his legs hurt. So the doctor's like, okay, we're going to take x-rays of his hips and knees. Just make sure, there's nothing going on. And so he did x-rays, and it was normal. The x-rays all looked good. So he told the parents, there's nothing going on with his bones, nothing that looks odd in his joints. So 2 weeks later, we're somewhere between 4 and 6 weeks out now, they come to me as new patients. And I literally in my mind can remember the pediatric oncologist on a Friday lunch saying 18% of pediatric cancers present with bone pain. I just remember that. I think that may be the only thing I remember from oncology. That oncology talk but it was that sentence that like 18% of pediatric cancers present as bone pain. So I told the parents, we need to just do some basic blood work. And so we sent the blood, they went home. And then at the end of the day, it was like 5 o'clock back then, 30 years ago. I was waiting for the labs to come off the printer. And my heart just absolutely sunk as I look at it. His white cell count was like 38,000. Platelets were low. He was anemic. I knew he had leukemia. And so I called the nearest children's hospital and made arrangements for them. And I was like, okay, so do these parents need to get 2 or 3 days of clothes ready? And they'll come in the morning. And the oncologist fellow, I think that was on that night, he's like, oh, no, they need to come tonight. Like, we need to put a central line in tonight and start therapy ASAP. And so that was one that from residency had stuck in my mind and really led to the diagnosis. Another one that actually happened in my first year of practice and then happened last year. So 27, 28 years apart. I was seen, again, this family had gone to a family doctor usually. And he had had fever and fatigue and some swollen lymph nodes, and they checked for strep. It was negative. They maybe had treated him with antibiotics anyway. I can't really remember, but I'm seeing him around the 2-week mark. And so he's had fever every day for almost 2 weeks by the time I see him, tired, swollen lymph nodes. And when I see him, his fingers are swollen, his eyes are a little bit red. And I'm fairly sure that he has what's called Kawasaki disease. And this was a doctor in Japan, Dr. Kawasaki, that figured this out 30, 40 years ago. And it's just a high inflammation over the whole body. Usually the body can clear it. They usually feel bad for 2 or 3 weeks. But what has been discovered 25 to 30 years ago is the inflammation can actually affect the blood vessels, the coronary arteries going to the heart. And they can form aneurysms, little ballooned areas in the coronary arteries of the kids. And so you have to do an echo and look at their heart when they're in the hospital a week later, or 4 weeks later, 2 months later, 6 months later. And the same thing about 6 months ago. I saw one of my patients on the second day of illness, 102, 103 fever, a little bit of a sore throat, a little bit of swollen nose, checked strep. It was negative. I'm like, probably just some other virus, adenovirus, one of the others. He may have fever for 3 to 5 days. So on day maybe 7 or 8, he's back. It was the day I'm out of the office. So one of my partners has seen him. And the mom's like, he still has had fever. And they're like, well, I guess he didn't look all that bad. And he didn't have any of the other symptoms, but the parents bring him the next day when I'm back in the office. And at that point, he has the irritated eyes, swollen red lips, his fingers are starting to swell. And I looked at the parents and I'm like, this is Kawasaki. There's like no question in my mind. I'm calling the children's hospital ER to let them know I'm sending you over. And they get IVIG. And it decreases the inflammation in their body. And I'm happy to say this one from 6 months ago, all of his cardiac echoes have been fine. So he will be released. So it did not cause any damage to his heart, but it's a fairly rare illness, but I've seen it at the first and towards the end of my practice. And having seen several of those in residency at Vanderbilt Children's Hospital is why I knew once I saw the other symptoms, I'm like, this is absolutely what's going on. Another one, I think, go to the next slide, I think goes with what I'm gonna, yes. So this little guy, I think this slide is his maybe 5-year well check, if I remember. I saw him as a brand newborn, 3 days old. And then he came back at 2 weeks for a 2-week check, and I was doing a circumcision because I do them in the office and they had not done it at the hospital. And so interesting thing, this little guy had 6 fingers. So he had 2 little fingers on each hand. So when I'm checking him out at the 2-week check, right before I was about to do a circumcision, I hear a heart murmur. And I hadn't heard the heart murmur when he was 3 days old. And there's a lot of change that goes on in the heart and lungs in the first few days of life. So we see a lot of heart murmurs in newborns that go away. And by the time I'm seeing them for their 2-month check, I don't hear it anymore. So most of them honestly mean nothing. Sometimes I don't even tell the parent that I hear it because it's gone the next time. But in this little guy, I remember when our genetic specialist was talking to us at Vanderbilt Children's Hospital. And I remember him saying the sentence, any child that has a congenital defect, so is born with an obvious abnormality is what that means. When you're seeing a newborn that has an obvious abnormality, and in his case, it was the extra digits, the extra fingers that he had on each hand, the risk of an internal congenital malformation or defect of some sort. If you're seeing one congenital defect, the risk of another one is I think 6 times higher than a child that doesn't have any type of defect. So I just could kind of hear that in my mind, like could this heart defect be a little bit more serious because he had the extra digits on his fingers. So I told the parents, I said, I hear a heart murmur. It's fairly loud. I didn't hear it last time. It's probably nothing. But because of the issue with his fingers, I think I'm just going to try to get you to the pediatric cardiologist within a day or 2. Let them check him out. If everything's fine, we can do the circumcision next week. So I make the referral. My staff takes care of it. And maybe 2 or 3 days later, I call the mom. Because I hadn't gotten a report back from cardiology, hadn't heard from her. Just wanted to make sure they were on the schedule there, honestly. And the mom picks up the phone and I'm like, this is Dr. Dutton. And I was calling to check on the visit. She said, oh, we're in the hospital. And I said, excuse me? She's like, oh, he's having open heart surgery this afternoon. And I'm like, she said, yeah, he had an interrupted aortic arch. That's when part of the aortic arch coming off of your heart is not, it's not the right size in all of the spacing of it. So parts of it are more narrow or parts of it aren't formed at all. And the mom said, hey, the cardiothoracic surgeon said, you need to tell your pediatrician, well done. This murmur and this defect is usually caught between 4 and 9 months of age, and often there's heart damage by that time. So again, it was kind of the geneticist putting in my mind the thought that if you see one congenital defect, there's a high chance that there's another one, and that's how I caught him. So I just wanted to say, as you head into medical training, it really is important to at least keep your mind open to the different specialists. And one of the things I would say to you going into it, because I realized this at the end of my training, if you feel like you're going to be a primary care physician of some sort, if you're going to go into family practice, internal medicine, pediatrics, maybe even OB-GYN, when you're listening to the specialists talks, if you have the courage to either say it out loud or wait till after the meeting and pull the physician aside, the specialist aside, it would be so helpful to you if you said to them, I feel like I'm going to go into primary care. I'm going to be an internal medicine. So as a primary care physician, what would be the 3 things you would want me to keep in mind from your specialty? Just the 3 things you would want me to know as an oncologist or as a pulmonologist, as a cardiologist, and those could be just diagnosis ahead of you that you're going to catch early, that you're going to catch well by just asking that question. So I just encourage you to think like that. Okay, I'm going to let you go back to the previous slide. Okay, and the last point on that slide is board scores and grades. It is so hard at this point in where you are in your junior or senior year in college, probably heading towards medical school or to become a nurse practitioner or RN or OT, PT, all of those different things. It is so hard to realize that not very many years from now, grades and board scores aren't going to matter at all. At all. They're everything right now to you. And there's a pressure and there's a weight on you because you need to get a certain GPA to even be looked at, or you need to make a certain score on the MCAT even to be looked at at the medical school that you're trying to get into. But there's so many more years ahead of you where grades and board scores aren't going to mean anything. And what's actually going to matter is did you learn what you needed to learn in medical school to understand the human body, to understand the disease processes, to understand what to order, to understand the treatments that are available. Those are going to be your lifeline when you get out. And I can honestly say, again, I'm in my 29th year of practicing pediatrics. And I can honestly say to you, in 29 years, I have never had a single patient parent, ask me my grades or my board score. Not a single one. I've had several of them that said, would you do it again? Would you spend the years in training again? Do you still love this as much as you did your first 5 years out? I've had a lot of great questions, but I've never ever had them ask about grades or boards. So I just want to try to throw that and give you a little bit of a perspective on this end. Okay, next slide. Choose personal excellence. There's going to be so much information that you're trying to process. And one of my concerns about the young healthcare providers of the next generation is that with Google search, you have been trained and you have practiced finding details and information and facts by just throwing them on a paper. And it is almost a disadvantage in my mind for your generation because you might associate facts with actual understanding. It's not the same. Just knowing facts about something is not the same as understanding the process. And you need to understand the process in medicine. And most medical schools, I think, still do training in that the first year is often normal function. What's the normal function of the lungs, the normal functions of the liver, the normal functions of the skin, the normal functions, and then you go into pathology, the disease processes. And it matters to understand all of those things. I would say if you're trying to get by with the minimal effort necessary, medicine's not for you. Choose something else. Don't take somebody's spot. Go into this expecting to work hard, but also expecting to be fascinated and intrigued, and also expecting to go, wow, people are literally going to be trusting their health and their life to me in the years ahead. What an honorable, serious matter that is. So I just want you to head into medical training with a desire to choose excellence in every place that you can. And again, choosing excellence, let me rephrase that. Choosing excellence not for your grades, choosing excellence not for your board scores, choosing excellence in order to do all that you can to understand the human body and the diseases that come against us and the choices towards health. Doing that in the best way that you possibly can. Next slide. And this is just a funny reminder. Please don't confuse your Google search with my medical degree. Google search will bring you to facts, but it doesn't necessarily bring you to the understanding that you are going to need to be a professional and to have people put their trust in you as their physician or as their nurse practitioner. Next slide. Who you are matters in medicine. Perhaps this is one of the subjects that I talk about more than other presenters do. And that is, I believe that the best physician you can be is the best total person that you can be. And I just want to encourage you, whatever passions and interests that you have going into medical school, if you play the violin, if I'm a tennis player, if you play tennis, if you like to inline skate, if you're a dancer, whatever passions that you have not connected to medicine, try to hold on to those during medical training. I found people to play tennis with during medical school, and you need to allow some space for those other things that are who you are. They need to survive medical training. And I remember coming to the end of my first year in medical school, I heard a sentence, and I don't remember where I heard it from. And the sentence was, never let the urgent overcome what's truly important. Never let the urgent overcome what's truly important. And all of medical training is going to feel urgent. It's just like there's so much to learn. There's so much to understand. And you've got these long shifts in the hospital. But you also will have other important things in your life. Maybe you're married by the time you're heading into medical school. It's important to keep your relationship with your husband or your wife intact and healthy. Maybe you already have kids going in, or don't lose all your best friends because of the hours that medicine requires of you. It's just important to keep those passions and interests. I also want to say to you, next generation healthcare providers, the last 50 years, medicine has operated in what I call a disease model. It really is about figuring out what's wrong with someone and how to treat it, usually with pharmaceuticals, in all honesty. But I think there's a change coming, and I think your generation is going to be a part of that change. And people are beginning to understand there's choices they can make in their 20s and 30s and 40s and 50s that can ward off the diabetes and the high cholesterol and the overweight, the obesity in our nation, and many other things. And so I encourage you to go into medical training with the thought of well-being being a part. And again, you can either minimize disease or maximize true health. There's just a perspective that can kind of make a difference of how you see things. And I meant to write it down and I didn't. So I encourage you to look up the World Health Organization, or maybe Michael or one of the others might be able to pull it up on a different computer. The World Health Organization's definition of health. If someone wants to grab that and maybe interrupt me at some point, then I think you would be fascinated by how the World Health Organization defines health. It's a wonderful definition. And I think as a physician, it would be awesome for you to put that, make a little note card and stick it in front of you while you're studying, because it's a wonderful perspective. Okay, next slide.
And maybe
this is another thing. No, go ahead. Yes.
Maybe if I can just add something quick. I did just quickly look it up. The definition they give is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
Yes, read that again, Michael, please.
A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
Yes, I encourage you to think about that as you go through medical training. That's wonderful. Thank you, Michael.
Definitely.
So this is another point that probably no other presenter may have talked about on what I call self-compassion develops patient compassion. And what I mean is that medicine is serious. It's a weighty profession because people's well-being is sometimes in your hands, and finding what's actually going on and being able to approach it early if it's a serious disease can affect the years of someone's life, or the quality of their life, for sure. But in order for you to stay compassionate as a physician, I believe you're going to have to give yourself compassion through medical training. Okay, if you cut off your heart and your soul and your emotions, the 4 years of medical school and 3 to 5 years of residency, if you're like, okay, it doesn't matter that I just had a horrible fight with my wife or husband, or it doesn't matter if I just found out my dad has a cancer, I've got to study for this board. If you're continuously shutting down the person that you are and the matters of life that are going on around you, then that is going to, how do I want to describe this? It's like the capacity in you to have true empathy and compassion towards a patient that has a life-threatening illness, or a patient whose family was in a car wreck and they all died except the dad standing in front of you, or just your ability to have true empathy and compassion is somewhat dependent upon you being compassionate towards yourself in the stresses of medical school, or with your best friends, or with a husband or wife, allowing you to just be honest. You need to have a best friend, or you need to have a husband or wife that you can talk about. In fact, I would encourage you to have a really close friend outside of medicine, because that's its own wonderful balance. But you need to be able to talk through and or cry tears when you lose a patient in medical school or residency, when you listen to a tragic situation, when you're in the emergency room and the double car wreck comes in and 3 members of this family and 2 of this other car are dead. And you're standing there thinking, these lives and these families will never, ever, ever be the same after this day. That should affect you. Let it affect you in medicine. Drive home from the hospital crying if you need to, or call a best friend when you get home and talk about how that impacted your own heart and soul. If you will do that, you will find that it's naturally preserving in you, or building in you, a compassion that's going to be there for your patient families. You're not going to have to struggle for it, because you allowed it to stay intact inside of you. So another way that I guess I could say this is, don't be so hard on yourself through medical training. All right. If you're stressed out, tell someone that you trust that you're totally stressed out. If you're not sleeping well at night because you have an attending over you this month that's very critical, very demeaning, you can't do anything right. I hope you have somebody in your life who knows the matters of the heart and soul enough to look at you, or on the phone to say, it sounds like that attending treats you like your dad used to. And all of a sudden you're like, oh my gosh, it's not just the stress of this month. These critical, demeaning sentences I'm having to hear from this attending on my rotation are what beat up my heart when I was a kid growing up at my house. Like, that's how real I want you to be. That's how I want you to, when I say I want you to live with a big heart, an open heart, that's also realizing the stress is going on inside of you. And please stay connected to that in medicine. I'm sure it's easier to shut it all down and just gut through. But I think the physician that comes at the end of that is one that will be impatient and not compassionate to the struggle of the patient in front of them. That's my opinion. So please stay real, stay connected to your emotions in medical training, give yourself compassion. If you need to go, I remember at the end of my first semester in medical school, so it would have been December, like the weather's not. So I just drove to Galveston and sat on the beach. It's like cold. It was like 50 degrees. And, I was in Houston. Just sat there at the end of the semester, just kind of, processing and just looking at the ocean waves and just like, whatever you need to do to stay you, it's important to do that. And in this, I can't remember if I have a slide that inserts it later or not. So I don't want to forget to say this. As you get out, and as you've been a physician or a nurse practitioner, PT, OT for several years, if you're interacting with a patient and you've done everything that you know how to do well, in explaining this, or you've listened to the symptoms, you've examined the patient, and you're thinking, well, this is just the onset, in your mind, something minor. Maybe this is early asthma, or maybe this is, it's not a, your mind hasn't gone anywhere near a serious life-threatening illness. And so you're like, well, we can get a chest x-ray just to make sure there's nothing else going on. Or if you've done all that you can and you're looking at the face, for me, a parent, for someone else, an adult patient, and you see that there's no relief on their face, even though they trust you. So I might have a patient family with 3 or 4 kids, and if I've seen them for 10 years, I know these parents well. So if I've done what I can and I still see concern, one of the most valuable sentences you could ever say as a physician is, what worries you most about this symptom? What are you afraid of with these symptoms? And all of a sudden you find out that Uncle Joe had symptoms like this 10 years ago, and he died in 3 months from pancreatic cancer. So so if you've done what you can and you don't see a relief or assurance on a patient's face, I so encourage you to look at them and just say, what worries you most about these symptoms? What is making you afraid about these symptoms? And sometimes it's just a family member or a friend that had kind of similar symptoms, and it turned out to be something really big, and it just can really open the door for your communication with the parent or with the patient in front of you. It can make a big difference. The last point on this, true versus false sense of responsibility. In my second year in residency, I did a rotation in pediatric ICU. I'm going to take a sip of water here. And having the heart of a kind of a primary care outpatient person, the ICU things always stressed me out so much. But I remember an upper level resident saying to me, Carrie, the kids that land in the ICU, whether they fell out of a second floor building or a horrible car wreck or a near drowning or whatever brought the kids into the ICU, without whatever care we render, they are dead. So we didn't have any responsibility in what traumatic event or illness or sepsis or meningitis or whatever happened. And so any step we take is to their advantage. And it just helped with the perspective of a false or true sense of responsibility. And those are the perspectives that can make a big difference in reminding yourself most of the time, any step that we're taking in medicine is an improvement from where they are. In other words, yeah. Okay, next slide. All right. When I started the presentation, I said it's very funny to be excited to be involved in something that I hope goes away soon. And what I mean by that is Zoom should not feel normal to you as a physician. Virtual shadowing is not the same as being in an office, listening to an actual heart, watching how I interact with parents and patients. And I really, truly hope that your generation gets back into settings very, very quickly. And neuroscience has been fascinating in what it has discovered in the last 10 years. That they have done PET scans with people in conversations or counseling sessions, and they've discovered that when a counselor is empathetically listening to someone share a tragedy or share a fear or share going on, that the synapses in the brain and the neurotransmitters in both sides create new synapses or new proteins of healing, simply because both parties are interacting in a healthy, caring way, that our brain actually functions to be connected to other people. And so neuroscience is basically starting to actually support what I'm just saying, that I think it's really, really important that you get used to being very close up in patient encounters and face-to-face conversations. I laughingly said at a previous virtual shadowing, if you are insecure with being, particularly with these last 2 years of COVID and everything's online and it all got crazy. Next family gathering, next Thanksgiving, next Christmas, it's someone says, oh yeah, Uncle Joe, he had cancer like 15 years ago, but he beat it. Maybe at some point you pull Uncle Joe aside and go, like, can I interview you? Can I just ask you like what the symptoms were and what you noticed and what your doctor did and what it was like having chemotherapy, what it was like having radiation. And then, by your third and fourth year of medical school, I tell people, like, assault your family to do physical exams. Like when you're home, listen to everyone's heart, look at everyone's eardrums, do everything that anyone would let you do to get your hands on actual people so that you understand all the different elements that can be normal in how a heart sounds, can be different but normal in how lungs sound, can be different but normal in eardrums. All the experience that you can get, including family and friends that will let you look at them or their kids or whatever, is going to be to your advantage. And I also want to say on this slide, our disease model also has created a fixing or cure model of medicine, like that we only feel completely fulfilled and confident if we fixed or healed or cured the patient. Okay, that's a process in medicine. And I want to say there's a whole lot of healing that we can offer with sympathy, empathy, and compassion, even if we can't fix what's going on. Even if this baby has a congenital anomaly, and it's a severe syndrome, and this little one's never going to be normal, and the family's always going to have extra things that they have to do, PT and OT and different things. I have the chance as a pediatrician to say, how is this affecting the rest of the family? How is this new development in your youngest child? What's the strain it's putting on your marriage? How are you interacting with your two other ones? So we have the chance to be compassionate, empathetic, and sympathetic, even if we can't fix something that someone's going through. And I just encourage you to do that, to be a healer, even when you can't cure it. You can offer healing with compassion and empathy. And again, to get as much face-to-face, close encounter interaction as you can with family, neighbors, or whatever when you're in the years of medical school and training. Like, listen to as many things and look at as many eyes and ears, look at as many tonsils as you can with family. That's not too invasive, heart, listening to our heart, listening to a lung, looking at eardrums, asking them to open their mouth so you can see their tonsils. I don't consider that invasive. So do as many of those as you can, and maybe some of them will let you feel their liver and spleen in their abdomen. It's just worth doing. Yeah. Next slide. Is this a good time to take questions, Michael, or do you want me to keep going?
I mean, I think maybe if we could just maybe go through this slide and then
okay, great.
Questions.
Yeah. Okay. So this is another unusual thing. Probably no one's going to talk to you about staying who you are, and no one else is going to talk to you about compassion like I did, or face-to-face interaction and how important it is. This is an interesting thing that I have great concerns about in the younger generation. You may not know unless you've been through a concussion yourself. I'm going to take a drink real quick. When I have the teenagers in that have had a usually sports-related concussion, one of the first things that we do is that in the first 48 hours after the concussion, they are not allowed to have any screen time. Not computer, not their cell phone, not the television. They can read old-fashioned books or they can read magazines, but not, because what we've come to realize, what the neurosciences have come to realize, is that the electronic devices make our brain work harder and faster than old-fashioned books. So in order to rest the brain so it can concentrate on healing from the concussion, we ask them to take a total electronic break for at least 48 hours. The neuroscientists have also discovered that it is in sleep and time not on a screen when our neurotransmitters are refreshed and can recreate themselves. So we can make the new proteins and things that our brain needs to work well when we are asleep or when we have screen time off. And the constant screen time of the younger generation between smartphones and the screen basically has, as far as I can see, has set your brains up for mental ADD, attention deficit disorder. It's all this different information, all these different points coming, at you that are unrelated, unconnected, and it allows the brain to just be concentrating, not very long at a time. And that's not going to help you in medical training when you need to understand processes, when you need to understand not just facts, but how this organ functions, how did the disease start? And so I highly encourage you, wherever you are in pre-health studies right now, in college, most of you, I would assume, I would highly encourage you to begin the pattern right now of 15 minutes a day, turning off every electronic device, or going to another room, leaving them in one room and going into another room and simply being present in that other room. If it's with a person, then neither of you has an electronic device and you're actually talking like normal, face to face in the same room, like you're going to be doing with patients someday. Or you can go sit and watch a sunset, or you can watch your brain. Next generation healthcare provider needs to slow down and process differently for medical training than what your life has been on social media since middle school and all that's been going on. And so if you can only start with 5 minutes, like that's all you can stand away from a device, then start with 5 minutes and try to work yourself up to 15 to 30 minutes a day where everything is off. I actually believe if you will do that, you actually will think faster, learn faster, and have better comprehension in your medical school classes if you have taken breaks, electronic media breaks. So I present that to you as something to think about and go, wow, could constant activity of the electronic screen actually decrease the ability of my brain to function and learn like it's going to need to in medical school? I believe so. So I encourage you to learn how to give yourself some electronic media breaks. Okay, it's yours, Michael.
All right, so we have a few questions that popped in. We'll start with one about your point about in-person shadowing, a few things to watch for. You mentioned for people who are interested in primary care and any specialists that they shadow, to ask them what are the 3 most important things to look out for later on as a primary care physician. One student is asking, she's going to start soon with in-person shadowing next week. What are some of the most important things I should be watching just generally, whether it be primary care?
Well, whatever you're in. One of the great general questions, if you're just starting with someone, is what are the things that you see most frequently? Like, so before you even start the day, you might go, what in your specialty or primary care do you see most often? So that's a pretty good question. And you might say, what's the most serious recent illness that you've seen in your office that might have surprised you or that was difficult to diagnose? And you might even be bold enough after you've been there a few days to maybe say, are you glad you went into this? Or at this point, would you have picked a different specialty or a different field? And I think one of the things that could impress the person you're with, just to let you know, because I did 2 previous virtual shadowing presentations in November 2020 and November 2021, I had a slew of pre-med students contact me. So I have had 11 different students in the last 13 months shadowing me. So some of them were just, once a week for 4 weeks. Some of them were half a day for 6 weeks, but I've had a lot. And, the ones that like at the end of the day were like, okay, so we saw these 2 patients and the symptoms seemed really a lot alike, but you ended up with a different diagnosis. Like, how did you know which way to go? Like, that's a great observation for you to make going in as a student. Because for me, I might say, well, a 3-year-old, this would be the most likely diagnosis with those symptoms. But with a 15-year-old, it's a different list that would be most likely going on. And so just, noticing those subtle things of those symptoms seemed like another patient we saw, but you went in a different direction on the diagnosis. Those are the kind of great questions you could ask.
And this is not a question listed here, but I thought it might be really important to ask. In terms of reflection after shadowing, when you are writing this down on an application, having notes for it, what are your pieces of advice for that?
Yeah, I appreciate some of the students that either on their phone or just, I have note cards that I have sitting around all the time, that maybe keep a list of diagnosis that we saw that day so they can look it up later. So when I write a recommendation, after I have a student with me, I write myself notes about the student in case they ask me for a recommendation letter a few months from now. So I'll write just 3 or 4 sentences, very interactive with the patient families. Like some of the students I've had, it was an obvious that the parent moms were easily connected, or maybe the kids always toddled over to play with the student. And I'm like, okay, they've got a natural connection with people, or maybe it was one that I noticed. They wrote down diagnosis that they could look up because when they came back, they asked me about those the next time. So it would be just, showing interest on what you saw that day. Or so if you were writing that on from the student perspective, it might be, I realized that a normal day with this physician was this dynamic. And the most interesting case we saw while I was there was this. And maybe the most heartbreaking case I saw during my time was this. So you've just showed that you noticed kind of normal, and then these things stood out to you that's from a student perspective, that might be what you could write.
Definitely. And then the next question we have, I guess we can cover a few. It was just about what you just mentioned on this slide here around screen time. So does that have the same effect if you're only listening to the media, not actually watching? Like, for example, they gave audiobooks as an example.
Do you know what? That is such a great question. And I don't know the answer. But that's a great question. I mean, I think you could probably Google it or something. Neuroscience or brain activity, video versus audio. You could literally probably find some articles on that.
Yeah, I'm sure.
Yeah.
In terms of you mentioned Speak Life Next Gen, a movement that you started for the next generation of youth. And you also mentioned, I think, one specifically for the next generation of healthcare providers.
Yes.
Were there any specific experiences during your career that motivated you, inspired you to start that movement? And could you maybe share a few?
Yeah, great question. Thank you. Yeah, the reason I started speaklifeng.net in 2019 is that over the last 10 to 15 years as a pediatrician, it has become increasingly obvious to me the level of stress and feelings of inadequacy and lack of joy that I've seen. And there are lots of pieces of puzzle. Like I watched over the last 15 years that normal sports, like if you would have normally been on a YMCA volleyball team or maybe baseball when you were 9 or 12, like you're hardly allowed to enjoy sports anymore. It's so competitive. So you've got 12-year-olds on 2 different teams so that they'll get on a better team next year. And they've got a private coach at 13 and they're exhausted. And by the time they go to college, they don't even play that sport that they played for 10 years and their parents spent $25,000 on, going to tournaments and all kinds of. So I was watching increased stress and less joy towards life in 15 and 12 and 10-year-olds. And I'm like, what in the world is going on? Why is a sport almost becoming a job? And why in middle school do you have to start taking all these honors classes? I mean, like you're supposed to have some years that you just get to be a kid. And I feel like I've watched that being lost in our culture. And that's why I wanted to encourage the heart of 15 to 25-year-olds. The website I basically is set up to try to encourage the heart and soul of 15 to 25-year-olds. That's the age I'm aiming at. And it was out of my concern as a pediatrician. It's seeing less and less just being kids and just enjoying life and resting and you know the social media coming in middle school for so many. There's so much viciousness. You know, I mean, I tell this to parents. I have this conversation like almost every week in my office. I'll look at a parent that's 30 or 40 or 50 and I'll say, listen, in our time, if there was a bully in our classroom that was bothering us, at least it ended at 3:30 when you left school. The bully did not come home with you. Okay. At least there was a break. And I said, now the bully comes home with you on your phone. The comments, the demeaning, the critical, the comparison, the competition. I just think the level of comparison and competition that starting about age 10, our culture lives under is destroying childhood and destroying joy from the teenage years. And so that was the incentive for the website, starting the website. Yeah.
Yeah. What a worthy cause. I mean, more than anything, I think we all realize it, but just we don't realize there's such a need for help there. It's not something to just be passive about, like you mentioned.
Yeah. And you know what? I was so grateful. I am not electronic, Michael, as you just discovered when we were trying to get going on this, and we had to use this old one instead of an updated because I didn't have whatever ready I needed to have ready. So I was completely overwhelmed at the thought of starting a website. But I happened to be, in 2019, I was leading a small group for a group of 6, 18 to 25-year-olds, just talking about life and the heart and God. And And I realized after like the second meeting with them, as I'm saying goodbye at, at the house, I closed the door, I walked back in, and I'm like, they at 20 are as emotionally exhausted as my generation was at 45 after they had raised a family and the husband, pursuing a career. And, you have this time in their mid 40s when the kids go to college and the parents realize how exhausted they are and kind of fall apart a little bit. But I was seeing that on 20-year-olds. And so I began to speak to that in the group. I said, I have to tell you, I was heartbroken last time. You guys walked out of here and I realized something came in my mind. And so in that group, in the honesty of that group, and them realizing that I was fighting for their hearts, I told them a couple months in, I said, I feel really strongly prompted by God that I need to create a website. And I have no idea what I'm doing. Zero. And they're all like, oh, we all created our own websites when we were 12, in middle school or this, or like, we can do this. We'll sit down and do this. So they went and found photos and they got me set up with WordPress and Vimeo for literally this group of 20 to 25-year-olds said, we're going to help you do this because you're fighting for our hearts. And so that was a gift to me. And then I had, from one of the virtual shadowing, I had a medical student that followed me last April and May. And then he ended up following the family medicine doctor in my group from like June through October. He's going to be a great, Jared is his name. He's going to be a great family practitioner. And he happened to be someone going back to medical school at age 35 after a 10-year career in software creation, software engineering. So after a couple months of him following me, he's like, what can I do for you? Thank you for being generous and kind in your time in the office. And I'm like, would you like to help me every 6 months update the website? Because I don't know what I'm doing. And so now he's involved. Anyway, it really just came out of heartbreak as a pediatrician, watching a lack of joy and enthusiasm in 10 and 12 and 15 and 18-year-olds. Yeah.
Pediatrics
Sorry.
definitely.
That was a long answer. Sorry.
No worries. We'd love to hear the story behind different, inspiration,
right.
movements. It's really wonderful to hear. And pediatrics was one of our most requested, if not the most requested specialty. Hearing how it left a specific impact on you that created this movement is just nothing but inspirational. So
great. Thank you.
Thank you so much for sharing.
Sure.
A few other questions just before we move on. Earlier, you went through a few medical missions overseas. Any stories or maybe specific patient cases that you can remember that you want to share?
Okay, so I have been, I worked for 5 weeks out with the Maasai in Kenya. That was my first medical mission trip in 1998. I went to Haiti twice after the earthquake in 2010. And the first trip out was just 2 weeks after the earthquake. That was the most overwhelming medical situation I have ever been a part of in Haiti. I was working with an orphanage that was kind of north of Port-au-Prince, a couple hours. So it hadn't been damaged. The orphanage had not been damaged. And they were well connected to some churches and organizations in the United States that could get more food to them. And they had some, rich businessmen with their own airplanes that were like, hey, we can fly supplies down. And so I went to this place and we had kids being sent to us for post-op care that had been in Port-au-Prince. And so one of the first ones was a 13-year-old, Katiana was her name. And her arm, one arm and half of a foot was amputated, and the arm looked like maybe somebody had hacksawed it out to get her out from under. It was an uneven bone cut. It would not have been orthopedics, in other words. Okay. But somebody got her to the hospital. And so I was seeing her in the days after for the care of both of those wounds. And during that care, I found out that both of her parents, a younger sibling and an uncle, died. And only she and an aunt had survived. And so you're just, you're seeing these wounds, and you're knowing that the life of these families and these kids are just never, ever going to be the same. And it was just such a overwhelming sense. And I had worked with a pharmacist in the area that my practice was. So I had known him for a long time, 20 years at that point, probably. And I had called him and I said, okay, I'm going to Haiti, and can I take morphine? Like, how do I do this? I don't have patient names. And he said, let me make a couple calls. He called whatever, pharmacy board or FDA, or he calls me back and he says, okay, like, what I can do is have you write it out. Cause I was trying to take liquid for the little kids, like 2 milligrams per 5 mLs or whatever, and pills, I think, for the older kids. And he's like, we're just going to have to do on the prescription label, like, use as directed for Haiti mission trip. And he says, if you get stopped in the airport in Miami, you're on your own. Like, don't mention my name. The pharmacist is basically saying, if something happens, but I'm willing to fill these prescriptions. And so he did. I had other friends praying the suitcases through that they would never be opened, and they weren't. It was amazing, right? Because if you scanned you saw gauze, you saw syringes, you saw tape, all this crazy stuff. And so it all made it over there, and I was able to use that. And I was in a hotel, I guess, right after we had arrived, before I was going to the location. And this man walks into the lobby the next morning, and I hear him telling the person where he's going. So he's going to be like 6 hours away from me. And it turns out he was an orthopedic surgeon from America. I mean, he's speaking American. And I'm like, hey, and I'm like, do you have all the supplies you need? I said, I had offices give me in the area. We've got 4 boxes ready. Another officer stop by in the next 2 days. We heard you're going to Haiti. I literally got enough supplies free from practices in the area that I used the Haiti supply for a total of 4 medical mission trips. Twice to Haiti and 2 more to Nicaragua 2 years later. Like, I had so much. And he's like, well, I wasn't able to get as much gauze as I wanted, and I wasn't able to get any morphine. So I gave him some supplies to the orthopedic surgeon that was going to be 6 hours away dealing with adults. And it was just, yeah. And the other case that sticks out is a little boy. So they were told they needed to come get some more kids to bring back. But a couple of them were in full casts, like from their mid abdomen to their knees. Like, if you break your femur, you have to be in what we call a long cast. And they're like, so they can't sit up in an airplane or a bus. And so one of the airplane guys, one of the private pilots, was like, well, we'll just take all the seats out and put a mattress down. And then we can bring like 3 of the kids that have to be laid out. So they did, they fly down, they bring them back. The airport is, he's landing on a grassy strip that looks like a park, right, in Haiti. And this little guy, he was 9 years old. A neighbor had heard him crying. So the house collapsed. His parents are dead. A neighbor hears him whimpering, pulls him out. And he takes him every day for 5 days to the hospital in Port-au-Prince. And because he doesn't have any bones sticking through his skin, they send him home. Okay. When I looked at the x-ray, his femur, the big bone in the top of your leg, the strongest bone in your body, the big bone in the top of your leg, it was crushed like 7 pieces. It was like in 7 pieces. You can't even imagine the pain he had to be in. But finally, it was his turn, and they did the surgery and put pins in. So they send a sheet of paper with parentheses, Johnny. So they've just named him. The orthopedic staff has named the kid. They don't know his name. They don't know how old he is. Like, Johnny. And they're like, this is what was done. This was the procedure. And then on his actual cast, this was so like, this is when you know you're not in the United States. Okay. On his cast, the orthopedic surgeon brilliantly with a Sharpie said procedure. Let's see, the earthquake happened on February 10th, if I remember. So procedure 3520, cast may come off 4/18/20, written on the cast. So wherever he landed, wherever he was going to end up for after surgery care, where they would have no idea how that was all going to place, we would at least know when the cast could come off. I mean, it was just we had a kid with severe cerebral palsy, and in the mom's rush to run out, she had dropped him like in a boiling pot of water. It's just like, ugh. And so you have to be sensitive in carrying him, and he couldn't walk anyway because he had severe cerebral palsy from birth defect. And I'm sitting there thinking, what can we do? And finally I go ask the person that takes care of the grounds, is there any way we could use a wheelbarrow for 2 days? Because I'm thinking we can fold sheets in the bottom of a wheelbarrow, and we can get him over where food is and back to the hospital, over to the clinic. And I mean, just talk about having to think on your feet. And then the other thing, which I actually consider an absolute miracle, where I was, because I'm not an orthopedic surgeon, and so I had not dealt with fresh wounds. That's not a big part of pediatrics. A youth minister from a church in Nashville, tattoos over half of his body. Not kidding. I wouldn't have wanted to run into him on a dark street in New York. Anyway, great guy. He comes to me and he said, I went to my orthopedic surgeon and I said, if you were dealing with fresh traumatic wounds, what is the one medical thing you would want to have? And the guy says, let me give you whatever we have. And there is gauze. There are gauze that's infused with antibiotic and Vaseline. So you can put it on an amputated area, and a day or two later, when I need to take it off to squirt saline and clean the area, it doesn't stick like a dry gauze might to a seepy wound, because it's infused with Vaseline and antibiotic specifically for amputations. It was a lifesaver to have these 2 boxes of probably 25 each that we were able to use on the fresh amputations. Yeah. And the kids having like asthma attacks, that I needed to give breathing treatments to 2 kids at the orphanage, and not kidding, like we're putting the medicine in to get it ready, and the electricity goes off. Because in third world countries, it can come on and off and routinely. And I'm like, they're like, let me go get the groundsman. So they go to the guy and he's like, well, I can run the gasoline generator to get electricity for a few minutes. How much time do you need? I'm like, well, give me 5 minutes. I'll get both of them going at the same time, because we had 2 outlets. So, we're giving the breathing treatments as fast as we can until the electricity goes off again. It just was crazy. You really have to go in. You have to be someone that can go into those settings and just be okay with what you can do, because there's going to be things that you can't do. I had a friend here in the healthcare that's like, hey, my husband and I, we want to buy you like 3 of the finger oximetries, and I said, I don't think I'm going to have access to oxygen. So I'm not sure if I want to know what their oxygen saturation is, if I can't respond to it. Just situations you just would never be in the United States. So my experiences in Haiti were absolutely the most intense situations I've ever been in. But God provided. Yeah.
Wow. I mean, nothing more to say than just that. What a story. What a story. I think maybe we'll just wrap up with questions for now, and once we get done with the slides, we'll save the
Okay.
rest of the questions for there.
Great. Great.
Right.
Primary care. So those of you that think you might want to go into internal medicine or family practice or pediatrics, there's a couple things I want you to ask yourself as you're going through medical training, because it's important. That will help whether you're going to be content in primary care, because it is different. In primary care, well checks, as we call them in pediatrics, or general health maintenance is the adult term, is as important as disease and illness. So in pediatrics, we're seeing them for well checks at 2 months, 4 months, 6 months, 9 months, 12 months, 15 months, 18 months, 2 years. They get vaccines at a lot of those visits. I'm talking about potty training and the will and temper tantrums and brushing their teeth. And you're going through just a lot of things in primary care that can be as important in the life and health of the patient that aren't diseases and illnesses. So does that actually interest you as much when you're in clinics in medical school and residency, when you get to go spend time in outpatient clinics? Did you feel the value of that, or were you bored? So if you're bored when you shadowed in an outpatient clinic, probably you need to be a specialist. would be just a little bit of a clue. So valuing the well checks and the general maintenance, where in an adult medicine, my practice has 2 pediatricians and 2 family medicine. So we see literally from newborns to 90-year-olds are coming in and out of our practice, which is wonderful to have that mix. But in the adult medicine, they're talking about heart disease and cholesterol and smoking and diet and stresses at work and things that can affect the wellness of their patients. So just primary care has as much of an emphasis on wellness care and health as it does disease. And going into it, you just need to be ready for that. The second point on primary care, are you willing to learn how to, what I call, embrace private life questions? So on the adult side, they might be seeing a 55-year-old or a 60-year-old for their general health maintenance. It's like, okay, remind me what you do for a living. Do you still enjoy that? Remind me how long you've been married, 35 years. Wow, congratulations. Do you still like your wife? Do you still enjoy doing things together? Are you still having sex? On the pediatric side, it might be like, okay, now that 2 out of the 3 kids are in school, does she miss when they're gone, or she likes having her time with you? Can you tell, is she connected more to one sibling than the other? Does that cause stress in the family? One of the COVID stories that I have is a patient family that has 3 kids, and they were all home. So, all of a sudden parents are trying to work online, and they're trying to teach kindergarten, 2nd grade, and 4th grade online, right? Everyone's home. So, the first question is, do you actually have 5 computers in what family? But anyway, I was seeing them after that. So probably the second half of 2021 for checkups. The mom had scheduled checkups, 2 of them on one day and the 3rd one the next day. And when I just said, okay, now that we're kind of coming to the end of it, how much stress was the COVID zone on your family? And she just humorously said, well, I might have on my own and personally kept the nearest liquor store in business. So I tucked that away in my mind. And I thought, when I see the next one next week, I'm going to actually bring that up. I'm going to confront, if that's the right word, this mom. So the next week I see the 3rd one. And I asked my medical assistant to come in and watch the kids, and I take the mom to a different room. And I said, listen, last week when you were in, you just happened to humorously mention, that there was a lot of alcohol consumption for you and your husband getting through that zone at home with 3 kids. And so many times I just presented it to her like this. Many times in times of stress, we reach for a crutch. And sometimes after the stress is gone, you're still using the crutch. And then that can become an addiction, and that can become a pattern that's destroying your life and your family. So I just want to ask you a question. At this point, are either you or your husband still drinking alcohol every day? And she just kind of looked at me, and this mom's probably 40, somewhere between 35 and 40 would be my guess. And she said, we aren't, but I so appreciate you being willing to ask me that question. But that's a private life question, but could have very much been impacting the life of the kids, which I'm their physician. So I have to be, willing to do that. So that's a more of a part of primary care. These hard questions that you might need to ask in order to really determine how things are going in somebody's life, because, that's another thing that the last 10 or 15 years, both cardiologists and neuroscience and all kinds of fields are now discovering how much life stressors affect our medical health well-being, right? That stress can increase your heart rate. The stress can increase your blood pressure. And if those stay up for months or years at a time, that can set you up for an early type of heart attack. So we're now understanding what's going on in the rest of their life really does matter to their health. And in primary care, I would say you really need to be willing to think like that and operate like that. The third point on primary care, connection to people more than processes. So it's in primary care. I mean, the patients often really feel like you're part of the family. They're talking about their doctors at Thanksgiving. And so there's a feeling in primary care that more than just the disease process that brought them in, which might be kind of more of a focus of a specialist, but more than that is the connection that you have with this family and being a trusted part of how things are working in the life of their family. And it's, I think it's one of the most powerful, honorable, and encouraging parts of primary care. Like, I gain energy and I gain passion back when I have a very serious, real conversation with the patient family that day. Rather than stress me, it's kind of like I waded into that difficult conversation well. And that's just more of a part of primary care. And I encourage you to look forward to that if that's what you want to go in. The other part of primary care is that you really get to enjoy the seasons of life in a patient family. Like, there's nothing in the world for me like seeing a little one when they're 3 days old. And then I can remember seeing them when they were 2 years old. And then I can remember when they're in for their kindergarten well check, and maybe they're singing the ABCs to me. And now there's been a new addition. A lot of times it seems kind of like at the 2-year checkup, a mom will say to the little one, tell Dr. Dutton our news. Tell her our new news. And the little one will, go like, baby girl. So mom's pregnant, basically, just some type of thing that a 2-year-old could say. And so it's just a sweet thing, to be part of the life of a family, or maybe one I've seen since they were 8 years old and now they're 16. Our office, the parent can sign a form that gives the 16-year-old or older has permission to come in on their own. So if they start, having a sore throat and fever at school, they can just come over from high school and I can check them for strep. So that's a season when they get old enough, they're like there without mom or dad. And that's something that you can actually really enjoy in primary care, is the seasons of life. Next slide. Okay, pediatrics in specific. A lot of times the students will ask me, what keeps it interesting? So for me, there's a few basic things that keep it interesting. All the time, I'm actually interacting with 2 patients at a time, the 6-month-old and the mom, or the 5-year-old and the dad. It's 2 different people that I'm interacting with. And so I that's part of the dynamic that just keeps it fresh in pediatrics. In addition, the opportunity to be a real cheerleader for the parents, to be able to go listen to, finish a 6-month-old checkup and go, she's thriving. You're doing a great job. Or maybe when I see a real stressed out, maybe at 2 or 4 months, I see the parents look really stressed and exhausted. And I'll just say to them, has this been the fastest 2 months of your life or the slowest 2 months? Or has this been the fastest 4 months of your life? And sometimes they're like, oh my gosh, it's been slow. And I'm like, okay, you look exhausted, or some of them will go, well, some days it's fast and some days it's slow. I said, that's honest. And if I see a patient, if parents come for a prenatal visit, if they're trying to decide what doctor they want for the baby, I will, first-time parents, if they're first-time parents, I'll say, I just want you to go into the first 6 to 8 weeks of your baby's life as if you had signed up for the Survivor show on TV. Just think about life like that. You don't know when you're going to sleep. You're not sure what you're going to eat, or if you're going to have hot food for 6 weeks because you're going to just finish cooking and the baby's going to cry to be fed. But it doesn't last forever. It's an exhausting 6 to 8 weeks. The baby's body doesn't have any pattern. Therefore, your life's not going to have any rhythm. But somewhere around 6 to 8 weeks, they start sleeping more at a certain time and eating, and you can run to Target and know that you've got an hour before you need to get back. But just even, just giving them the right to be exhausted and overwhelmed. And just like, it's not going to last forever, but yeah, it's kind of like you signed up for the Survivor show when you had a newborn. And just that can give them humor and a chance to think through it like that. Education rather than antibiotics. I'm a huge advocate and have always used, I have a handout on your child's fever, your child's cold, vomiting and diarrhea, croup, that just talks about what causes these things, when to be concerned. And so pediatrics, there's tons of illnesses that children will have 102 to 105 fever. Okay. And it terrifies the parents. And if you or I had 103-point fever as an adult, we hallucinate. Like, we see spiders on the wall and stuff when our fever gets that high. But kids get high fever with a bunch of illnesses that their own body takes care of. It just viral illnesses. 90% of fevers in pediatrics are viral illnesses that do not need antibiotics. Their own body will fight this thing off in 3 or 4 days. The fever will be gone without anything. And so I use a lot of education so that I'm not overusing antibiotics. And then I think the final point on this, trusting follow-up. One of the best parts about private practice is actually being able to trust follow-up. When you're in medical school and residency, the clinics that are connected with them, you often, or the emergency room for that matter, you don't know if this patient's coming back or if this parent's going to bring the kid back when we asked them to. So that tends to lead you to have to do as many tests and things as you can in that moment. Versus in my office with a family that knows me, that trusts me, I can go, I think this is just the virus we've been seeing for several weeks going through the kids. And I've seen a bunch of kids with 102 to 105, usually 3 to 5 days, and then they turn the corner. And I'm like, but he looks just a little bit worse than I'm used to seeing your son look with fever. Maybe he's 3 or 4 years old and I've seen him. And I'm like, I would like to see you back tomorrow and take a listen to his heart and lungs and look in his ears and throat again tomorrow and just make sure nothing has, or a lot of times a patient I'm concerned about, I'll send a note to my nurse that says, please call them first thing in the morning, ask how the night went. And if there's still concerning symptoms, I'd like to see him again. And so that's another thing that can keep you from overusing medicines that really aren't needed because you have follow-up. Yeah, you have the chance of follow-up. And so that's a wonderful part of private practice, primary care, is being able to trust follow-up and ask the families to come back if you feel like you need to see them again. Yeah. Okay, next. Medicine in general. Oh my goodness, I just so wish I could impart to you that it's still such an honorable field. Even in the stress, even in the, am I going to make a mistake? Am I going to miss something? You are. If you're going to be in medicine, as long as I've missed some things. I've not done some tests and I see the kid and the next day I'm like, I'm sending you to the emergency room. They're going to need to be doing, so yes, there are stresses to do with medicine. But it is such an honorable field. And I really want to I want you to know that it is your patients. You mean more to your patients than you realize you do as a physician. They are depending upon you more than you think they are. And they're trusting you a great deal. This next point I call the sanctity of the exam room. If we did two strangers at the grocery store what were in a patient room and having them take off 3/4 of their clothes and listening to their heart and lungs, feeling their liver and spleen, like you'd be arrested. Right? You'd be, the police would be coming if you were doing an exam outside of the sanctity of the exam room. And so even that it can seem so routine. Medicine can seem so routine, and checking, listening to a heart, lungs, ears, throat, feeling the liver and spleen to make sure they're not enlarged. That can become routine, or you can learn to remind yourself as you open the exam room that this patient is trusting. They're trusting me with the well-being of their children. They're trusting me to examine their children in an honorable way. And there's the questions that are asked in the exam that's done, and the explanation to look at a parent and go, I don't want you worrying about this 103.5 fever tonight. I'll worry about it. And we'll talk to you in the morning and we'll see how, and there it is. I think that the exam room is a sacred place. And I wish physicians and nurse practitioners could feel that and sense that and be reminded of the field that we're in and how unique it is, how very unique it is. And let that be a blessing and an encouragement and a strength to us instead of just stress all the time. Healing versus cure, I talked about when we were talking about face-to-face, just being compassionate and empathetic, recognizing if your patient doesn't seem assured, you can ask, like, what is most worrisome to you about that? Let's see, I'm going to have you go down a little bit so I can see the rest of a partner in patient health. That's a big part of asking the private questions of, really, for adult medicine, what is their diet really like? How much alcohol do they drink? How much stress is their work for the kids? For me to start asking the questions at 10 or 12, how much time do they spend on their cell phone already? Are you monitoring that parent? You ought to take that 10 or 12-year-old's phone in your bedroom when you go to sleep. Do not leave that cell phone. Turn that computer off, on particularly the younger, the 9, 10, 11, 12, 13, 14. I'm like, you cannot guard them enough because they are growing up in a predator environment. Yeah. So, just kind of going through the different issues of health in an honest way with the families is just a big part of medicine and is a wonderful part of medicine. Next slide. Oh, the other thing I hate for you guys is that you've been in the COVID zone and you've had to go to classes online in college instead of in person, and even the medical schools. I had to kick out the person that was shadowing me in March of 2020, who had been shadowing me for 6 months. And there's so many things I want to say about this that some of them would get me in trouble. Let me go on to the next slide and we're going to come back to this. I think this is okay. So I know this one's a little bit blurry. I'm sorry, but this isn't an adult medicine. Okay. This is the top 10 causes of death. This is 2019, if I remember. 18 and 19. It's got 2018 and 19. Heart disease, cancer, unintentional injuries. That would be like car wrecks. Chronic lower respiratory disease. That would be asthma, COPD, stroke, Alzheimer's, diabetes, kidney, influenza, suicide. Okay. Those same ones are going to be 9 of the top 10 when COVID slides in at number 2, 3, 4 for 2020 and 2021. But these diseases still are going to be the top ones killing people. And I just want to give you that perspective. If you are in college, by the time you're done with medical training, COVID will be nothing more than the winter flu. I know that seems crazy, I know that seems radical, but that's the reality. Okay, go back to the last slide for me, Michael. Thank you. One of the things I wanted to say, the Spanish flu in 1916 to 1918, they estimate that 60 million people died worldwide from the Spanish flu. And now, of course, that was before there were IV fluids and there weren't IV antibiotics or antibiotics by mouth. So the pneumonia that it turned into, you were going to die because we didn't have any treatments. But even 60 million people dying of the Spanish flu that year, our world, 100 years later, the crisis of our world is too many people. Even after the last big pandemic took out 60 million people, 100 years later, we're 2 billion more. That we're between 9 and 10 billion now. Okay. So I want to say we have a brilliant immune system. God gave us a brilliant immune system. It can handle illnesses. The world has continued to expand in population after, whether it was the bubonic plague in the 1400s, the different, they come at about an every 100-year pattern. A huge pandemic is about every 100 years. And then those that survive, the world continues on. And that's exactly what's going to happen with COVID. And I don't mean to minimize. There may be somebody watching this and a mom or a dad or a grandma died of COVID. I'm not trying to minimize. I'm really not trying to minimize. But what I'm saying is, do not let your medical training be all about COVID, because so many more illnesses that were killing adults or killing children before COVID are still doing it. In fact, I think half of all COVID deaths were normal ones, were normal heart attacks, or normal strokes, and the person happened to be positive. It'd be like a winter season. If everyone that walked through the emergency room in a normal winter, we checked for a cold. And if it was positive for that winter's cold, we put that as part of the diagnosis of why they came in. Whether it was for stitches or pneumonia or something else, if we counted that diagnosis, that's kind of what we did with COVID. So I don't even think the numbers are true. But anyway, as an infectious disease, it's not our top 10 list that continues to kill most people in America, like heart disease, strokes, kidney disease, diabetes, those kind of things. And so I just want to throw that out at this point in your medical training. It's just not all about COVID. Okay, you can go 2 more slides. Okay, if that one didn't get me in trouble, this one will definitely get me in trouble. You are not all mentally ill. One of the concerns that I have for the younger generation is that somehow our culture or social media, I'm not sure how it happened. We have allowed you to believe, or told you to believe, I'm not sure how it happened, that the feeling of stress, tension, effort, uncertainty, feelings of inadequacy, that any of those must mean anxiety and depression. Can I tell you, middle school has been hell on people's emotional well-being for thousands of years. The puberty growth spurt, everything's changing in your body. Your thoughts aren't functioning normally during the puberty growth spurt. You're making decisions that get you in trouble. You're in fights with your parents. Kids at school are all in different stages of change in their bodies and the hormones and everything else. So all of that is chaos. That's been chaos for 500 years. But now, if you're feeling inadequate, uncertain, if you're comparing your body to the person sitting next to you as a 12-year-old, then you must be anxious, depressed, or uncertain about your gender. That's crap. That's crap. So I'm just going to say that's a lie. And I pull off of you, next generation healthcare provider. I just pull off of you the deception and the fog and the lie that stress, tension, inadequacy, uncertainty means anxiety or depression. It doesn't. Life will have uncertainty, stress, and tension at different seasons. Do you change jobs? Do you move to another city? What should we do with this teenager that's acting out? Do you think they're doing drugs? Like, life has places of uncertainty and fear in jobs, in being parents, but it's not anxiety and depression. It's a season of life that's really hard right now. Don't let it give you a mental diagnosis. the thought that 10 or 15% of college students are on anti-anxiety or antidepressive medicines to get through college, we're doing something wrong as a culture. We are not doing our jobs of giving you confidence and grace and mentoring in your teen years if you are stressed out by college. And so I'm just like, next generation pre-healthcare. Let stress just be stress. Let tension be tension. Let feelings of inadequacy just be part of life at certain seasons. And just let it be okay. And stay and have a couple close friendships. You just got to have some close friendships, but you're not all mentally ill. And all of stress, tension, inadequacy, and uncertainty do not need a diagnosis. Yeah. All right. Next one. So if I had to summarize this place you're in pre-health care, as you're heading to pre-health care training, are you willing to work hard for this? Like, really ask yourself. This next generation in their 20s, not in pre-health care, just normal life, kind of has a reputation that if they get a job and they don't like it, 2 weeks later, they quit. They'll just go get a job somewhere else until they find one that they like. Well, that's not going to work in medical training. Like, you need to decide, am I willing to work hard for this? There are going to be some subjects that aren't interesting to me because I can remember I knew I was going to go into pediatrics probably the first year in medical school. And so it was really hard for me to focus on my surgery rotations. I wasn't going to be doing general surgery. I wasn't going to be doing oncology surgery but there were things to learn. It was the surgeon still like, let's talk about the blood supply going to the breast, since we're having to do this mastectomy for this lady with cancer today, so just you've got to be willing to work hard for this and to not give up. Are you willing to sacrifice because details matter, facts matter, comprehension matters, conceptual understanding, again, not just Google searches, but really understanding the human body and the disease process, and experience matters. That's why I want you to get back into offices, and I want you to shadow in emergency rooms. And when you get into medical school, I want offices to welcome you back in shadowing, because it does matter. It does matter. Healthcare training should not be easy. So I don't want them to make it easier. It doesn't have to be brutal, but it's not easy. It's a complex, amazing system. So then I said, legalize common sense. Let's just get back to some common sense every once in a while. Okay, next slide. Next generation healthcare provider, you can do this well. I want you to hear somebody who's been in practice 29 years. I wish I could look each of you in the face that will ever see this. Hold your face in my hands. I honestly do. And wish I could just say, you can do this well. You can do this well. You can do this with your heart intact. You can do this with empathy and sympathy and compassion for yourself, and then subsequently for the patients that you'll see in the future. You can do this well. You can do this well. Man, some of you might just have to, just like you might have to practice, feeling overwhelmed does not mean inadequate. Feeling overwhelmed does not mean inadequate. Feeling overwhelmed does not mean I'm inadequate. Just like you might have to practice that sentence. You might have to practice this. I can do this well. No matter what my feelings are this week about the upcoming test or not understanding that last lecture, I can do this well. I can do this well. Say this to your peers in medical school. Be the bold, crazy, outrageous one, like me. Be willing when you see someone losing heart that sees they made a C on that test, or they didn't understand pathology or physiology. You be the one that walks over there and goes, I believe you can do this well. This was just one lecture. This was just one test. Don't let one test, don't let one grade define you. Don't let it. You can still do this well. You guys need to encourage each other. Yeah, yeah. In medical school, you need to be positive encouragers to one another. And that's one of the ways to guard your heart and soul remaining intact is for you to just go and say, I'm going to be an encourager in medical school. I'm going to be the one that's encouraging people. So I encourage you to do that because you can do this well. You can do this well. Okay, last slide, I think. Oh, blessing, and we ran out of G. I just want to take the opportunity to say a couple statements of blessing over you that I hope can encourage your heart. Next generation healthcare provider, you can do this well. Who you are matters. Your years of training are going to give you the opening and the opportunity to interact and influence thousands of patients' lives. Next generation healthcare provider, I bless you to get through medical training with your heart and soul intact. Next generation healthcare provider, I say you have a brilliant mind. You have amazing neurotransmitters. You have a larger capacity for comprehension and understanding than you think you do as you're watching this today. I bless your brain and your mind and your neurotransmitters. I speak life to you. I speak encouragement to you. I say, go for it and go for it with a large heart. And so many patients ahead of you will be impacted by that. And I thank you for this opportunity to speak to you today, and we'll take some more questions.
Well, I just want to say before going through any questions, this was, one of the most informative and at the same time inspiring sessions there's ever been.
Great.
We definitely do appreciate, and I'm glad we got this together to not only talk about a specialty that so many people wanted to see, but also discuss so many things that are not touched upon enough. I really have to owe you a thank you, Dr. Kerrigan. Yeah. I'm sure everyone else would say the same listening to this here. Nothing but thank yous.
Yeah, thank you, Michael. The replies I got back after my first virtual shadowing in November 2020 overwhelmed me. And I realized, oh my gosh, what they need is not more technical advice on MCATs and medical training and what specialty. They need someone to speak to their hearts. It was so, the replies I got back by email were so, like I had decided to leave pre-med and was going to tell my parents on spring break. And I happened to be part of the live 700 virtual shadowing. And I realized I can do this with my heart and I'm going to stay pre-med. And that's why I was just like, you know what? Whenever I have a chance to talk, I have to speak from my heart because I'm willing to, and I'm confident enough to, and I'm not afraid to. And I want you guys to have your heart intact when you finish medical training. Yeah.
Yeah, we really do thank you. And that what you just mentioned was just a testament of how impactful it is. But I guess just to jump into the last questions we have to wrap up the session, we have a question that came in kind of about the opposite way of things, of how doctors might catch viruses or infections from patients. How do you avoid that? Going visit.
So mine's a little bit different. I did a lot of babysitting in middle school and high school. I had probably 15 different families that I babysat for and made some extra money. And I think with that, I had exposure to a lot of routine pediatric illnesses. So I for the most part, even in medical school and residency, didn't pick up very much. And some of the other residents that I was with at Vanderbilt Children's Hospital, oh my gosh, they were sick all the time because they really hadn't been, around much. So I would say, particularly post-COVID, do what you can do to strengthen your immune system, right? Get your vitamin D level up. If you don't like glasses of milk anymore, start on some vitamin D and calcium supplements. We've discovered through COVID that vitamin D isn't just about keeping our bones strong, but it actually has a lot to do with our immune system. So I would say, look into things that talk about certain herbs, certain foods, and certain vitamins that have most to do with your immune system, and do those two if you've got some college years left while you're listening to me, go ahead and start doing things that can actually strengthen your immune system. Because I do think it help if you're not someone that's been around a lot of different ages just in your family. Some families, the little ones are around and grandparents are around. And so there's just a natural exposure. So your immune system has gotten to build up, and other people maybe not so much if they didn't have big families that they were around with different generations. And that you could kind of look up different supplements, vitamins, diet that can get your immune system ready for that. Yeah, that's a great question.
Definitely. Thank you for your advice on that. You mentioned, going into this next question, you mentioned a little around private practice. Although a student asked, how is your experiences with private practice compared to working at a hospital, which you might have received some exposure from going back to residency?
So, yeah, it was obvious to me in residency, my peers that dreaded going to what was called continuity clinic. So in residency, you are already able to have a clinic that you're at like half a day a week. I think half a day a week. It used to be only your third year. Now they start at your second year. And so you actually have patients that you're their doctor in residency. So they're coming to see you for their checkups. And so that can kind of give you a sense of if you were in private practice. So the ones that became specialists hated going to their continuity clinic. It was absolutely boring to them. Versus I was totally stressed out in the NICU and the pediatric intensive care unit, because those were not my style. So if you find yourself more interested in hospital care as you're going through residency, then that's probably what you need to go into. Yeah, you may be a personality that finds the most fulfillment in taking care of this critical medical need right now, and you don't really have an interest or need in follow up the next few weeks and months. So, we need all types. We need ones. So, yeah.
And this is kind of a similar follow-up, I guess, in a different form of a question to what you just mentioned there. Overall, I mean, just from what you mentioned in your presentation, we can tell how there's been multiple forms of involvement in pediatrics that you've had with overseas missions, working at private practice, your residency days, a lot of involvement in multiple forms of that. How has that expanded your interest and understanding of the field in general?
Oh, what a great question. So the intense situations that I was in medical missions certainly made me grateful for medicine in the United States and the availability of treatments that we have. So that is, I think sometimes just the day-to-day and the stress and the weight of medicine on you can still a gratefulness for medicine in America. We have a pretty great system, and we can usually figure out what's going on. And so I think just a gratefulness came into, and the other thing that medical missions did, which was interesting too, is some things like the Academy of Pediatrics does not recommend in any way co-sleeping with kids, right? Your baby needs a bassinet, and then it needs a crib, and then it needs a toddler bed, then it needs its own bed. Do not sleep with parents. All right. So I come back from countries that mom, dad, and 5 kids live in one room, right? An 8 by 8 foot room or hut when I was with the Maasai in Kenya, out in the outback in Kenya. And you're just like, okay, so when I have a parent ask me, I know I'm not supposed to do this. I know this is a bad habit my husband and I have gotten into, but it was so hard. When she went from the crib to the toddler bed, she wouldn't stay in bed. She always ends up in our room. And so I'll go, well, I can tell you what the Academy of Pediatrics tells me to tell you. And I can tell you the reality of 50% of families in the rest of the world, in rural Russia, in rural China, in most of Mexico, in most of South America. Like the whole family's on one mat, or the whole family's on one mattress. Like that's just their life, even in 2022. And so obviously those cultures have survived and they have more kids than we have. So I think I have a little bit more of an international perspective. Instead of trying to have perfect families and perfect medicine in the United States, I have a little bit broader perspective, which I appreciate. Yeah. Yeah.
All right. And I guess we can wrap up with two more questions. So
Sure.
again, specific to your field, what were the challenges you faced? I mean, it could be at any point in time, whether it was residency, even late into your career, specific challenges you faced to pediatrics, and how would you advise that anyone listening who'd like to go into pediatrics or primary care in general, how would they go against and overcome them?
So all of the children's hospitals that you would do your residency in the United States are intense places. Okay, the sickest kids go to the children's hospitals, whether it was Vanderbilt or I'm here in a suburb of Dallas talking to you, and we have Children's Health, we have Medical Cities Children's Hospital, and we have Cook Children's. So we have 3 children's hospitals, in a 40-mile radius. So you see the cancers that are only 1 in 300,000 kids, or you see the defects or the genetic defects or the metabolic things. And so you see the hardest things, and they die, right? In residency, they don't all make it because it's the most serious of illnesses. And I remember in the intensive care unit, I forget what the little one baby came in with. It was 5 months old, 5 or 6 months old, but we had done the test. The baby was brain dead. And so they suggested that the family take off the ventilator and everything. So I remember the nurses brought a rocker in. We took everything off the baby. The baby stopped breathing, heart rate stopped. And we allowed the mom to rock the baby, the now dead baby, in the final few minutes. And this is 30 years ago, and it brings me to tears. I remember thinking, how would you go home to an empty crib, an empty baby's room? Right? I mean, it's just like, whew, wow, that's heavy. In private practice, for the most part in pediatrics, children get sick fast and they get well sick fast. So, they're fine this morning, and school calls, they had 103 fever. Maybe it's strep throat. Maybe it's just the virus we've been seeing. But 4 days later, they're completely back to normal. That's much more the norm. It's maybe 1 or 2 serious cases, maybe new onset diabetic, or like I shared about the leukemia or the Kawasaki. Well, probably more than 1, maybe 3 to 5 serious cases a year. And a couple thousand routine well checks and routine illnesses, so that's the balance. Yeah.
Definitely some challenges to face there. And hearing from your reflections, I think we can understand not only a little of, how you can go about them, but also definitely hear from your experience. It's good to hear.
Yeah, you need to. I remember calling my best friend from college when patients died. I think she was in California. I was in Houston in medical school. And you need to process. Oh my goodness. You need to let it break your heart when a wife is just sobbing and sobbing and sobbing and sobbing because her 45-year-old husband had a heart attack and they have 3 little ones at home. That's heartbreaking. And yet at the same point, you're in training and you've done everything you could do. The team, maybe they were found outside and had collapsed 10 minutes before, and the heart's not been beating for 5 minutes, but they brought him in and we coded for 20 minutes and we gave all the medicine. And finally someone, that's probably the weirdest part I can remember in the emergency room, is when you go from full flurry, 5 different people doing things and shouting things when a little one comes in with a cardiac arrest. And then whoever the team leader is finally looks at the clock to see the time of death and says, I'm calling this code. And you go from absolute fury of an activity to everyone steps back with their hands by their side. And you're about to tell a parent that their little one didn't make it. You just got to process. That's not normal. less than a 1 in 1,000 people in our culture will ever experience something like that. And so those unique experiences was why we need close friends and to talk through things and to be real about our hearts in medicine.
Absolutely. I mean, I don't really think I have much more to say. It's just so much emotion behind it, but you can't even get the words to describe, right?
Correct.
I guess we can just end off on this last question. And really, to sum up the question, it's any last pieces of advice you'd have for these young, aspiring doctors, nurses, PAs listening in?
Yeah.
Maybe about time management, work-life balance, really anything that you'd like to discuss to end off.
I want you to know that medicine is a wonderful thing to give your life to. Medicine is a wonderful thing to give your life to. That's what I would say to you. So it's worth the years and the hours of medical training. And it's worth it even more if you can get by and get through it with who you are in your own heart intact. Yeah, who you are matters. Who you are matters. It matters the kind of physician that you're going to become. Don't lose you. Don't lose you in medical training. That would be my final word of advice.
All right, that sounds great. I mean, I think it's stayed true to everything that you've said this whole presentation, and there's been a lot of insight, a lot of information there.
Good.
So I think that will wrap up today's session. What a wonderful session it was. We've had, I think, pediatric nephrology once, but we did not have pediatrics as a standalone specialty before. So this is definitely something that a lot of students have been requesting and waiting for. We're glad to deliver today. So those who are listening in, for our shadowers who are listening in, to earn credit for your attendance, you must pass the quiz to receive a certificate, and that certificate would be sent to your email, the one that you input in the quiz. So make sure if that's a school email, a personal email, make sure that's the one that you want to get it sent to. We have posted that quiz link in the chat box, and it's available also on our website under the virtual shadowing page. The quiz will be due at 11:59 Central Standard Time on this upcoming Wednesday, June 1st. Just like all other quizzes, we always set deadlines as the following Wednesday, 11:59 p.m. CST. After passing the quiz, like I said, you'll receive a certificate to your inbox. Although if you don't find the certificate in your inbox, please check your spam folder. If it's not there, feel free to reach out to us. Our email is shadowing.h4h@gmail.com. You can reach out with any questions, whether it be about certificates or anything in general with virtual shadowing. So that's actually going to wrap up our whole spring 2022 semester. We've had quite a few sessions, and I just want to thank not only Dr. Carey here, but also those listening in for your attendance, your participation, the questions you've put in, and the enthusiasm that you've had with each session. We really do appreciate it. We're going to be having a break through the month of June. So all of June, we'll have a break from shadowing sessions, and we're going to resume with shadowing sessions starting in July, which will start and kick off our summer 2022 semester. And I believe that's going to be over urologic surgery with urologic surgeons. So that's going to be a good one to start off with. If you'd like to, like I said in the very beginning, keep in touch with future session announcements or just general information, we have a few programs rolling out. To name one in specific, it's Medical Miracle Mission about clinical volunteering. If you're interested in getting any clinical experience, I heavily recommend that. We have our application and the posts about information and details around the program posted on not only our Instagram, but also on our email listserv. So if you'd like to join either, follow either, feel free to, again, just follow our Instagram. It's the handle hearts_for_health. That's all. Or you can join us through our listserv by emailing us with your name and email address, or just subscribing on our subscription form. But with all those said, I just want to give one last thank you. And we did have plenty of people reaching out with thank yous over the chat, Dr. Carey. So again, we really do appreciate your time. Sure. It was definitely, I mean, for not only me, but everyone listening in, on behalf of not only me, but everyone listening in, we definitely appreciate the time that you give. And if anyone wants to reach out, feel free to. We can, I'm not sure if they caught it. I can share my screen again. The email that you have, Dr. Carey, for any students to reach out to you.
Yeah, it's all the way back to maybe the second or third slide. Right there. Go up just a little bit on the slide. There you go. speaklifeng at gmail.com, which is speak life to the next generation. speaklifeng at gmail.com.
Yeah, feel free to reach out to Dr. Carey there. And like you mentioned, Dr. Carey, if you happen to be in the Dallas-Fort Worth area, maybe you can get some shadowing scheduled with Dr. Carey.
Yeah.
If availability is there. But yeah, that was all for today's session. Again, thank you so much, Dr. Carey.
You're welcome.
Definitely. If anyone has any questions about shadowing, let us know. But I guess that will wrap up today's session. It was such a wonderful one. All right.
Bye.